Hi, Dr. Choll Kim here from sunny San Diego, California. I'm at the North American Spine Society meeting together with all my esteemed colleagues, including Dr. Deepak Reddy from South Bend, Indiana, and he is an expert in a surgery called ALIFs. That is the surgery that Tiger Woods had. So I have lots of questions.
Thanks,
Thank
Joel.
you.
Thanks for including me.
Tell me, from a patient's perspective, if I need a lumbar fusion for a reason, and I seek a couple of opinions. One doctor says I should have an ALIF. Another doctor says I should have a TLIF from the back. Another doctor says I should have an XLIF from the side. How do you decide which procedure to do on a patient? And somebody that's looking at an ALIF, kind of what should they be thinking about and concerned about?
Sure. So, whenever we do lumbar fusions, there's always multiple approaches that we can utilize, and they all have different risks, different benefits, and different reasoning behind choosing them. When we look at ALIFs, or anterior lumbar fusions, we're talking about doing fusions through the direct front of the spine, so accessing the spine from the front through the abdomen. And that can be a procedure that's a very powerful procedure that we're able to utilize really well at the lower aspects of the lumbar spine. So classically, guys who are doing ALIFs or surgeons who are doing ALIFs are doing L4-5, L5-S1 are probably our workhorse levels that we're trying to access. And there's certain considerations that would drive us towards an anterior surgery, some of which have to do with patients' previous surgical history, some of it has to do with their specific pattern of degeneration and what our goals are. So if we're really trying to create a lot more disc height and a lot more angle at the base of the spine, a lot of surgeons will favor an anterior approach to utilize that.
Yep.
And if we can do it through one surgery and an anterior approach and spare some of the muscles in the back of the spine, we feel like the patients do pretty well post-operatively in terms of getting back to activities like golf or tennis or pickleball.
Tiger Woods.
Correct.
Standalone ALIF. So I think what Dr. Reddy's talking about is it's an exciting time in spine. The technology is really growing, and now we have a lot of options on how we take care of patients, which is great because, let's face it, patients are unique and every patient's different. And the
100%.
more tools we have to address the unique characteristics of each patient by having a large tool chest, that's to our benefit. So going in from the front, everyone's a little scared about it because it seems like you're going through the stomach. But one advantage of going from the front is that you could put in a big implant because the nerves aren't in the way, because a lot of times the nerves are in the way. And when do you need a big implant? Like, what's the major advantage of going in from the front with a big implant?
So one of the major considerations when we're doing fusions is how much correction are we attempting, right? There's sometimes where you need a fusion, but the spine's in a pretty good position to start with, and you don't really have to reshape or force the spine into a new position. But in situations where you're really trying to recreate normal anatomic parameters, where you're taking people who have degenerated so far that they've kind of deviated from the normal path, we really have to put a lot of force into the spine to get them back to where we want them to be. And when you're adding those implants, you really want bigger implants in those scenarios to spread that force over a greater amount of area so there's less pressure on any one point in the spine.
So for example, somebody that has a lot of high demands on the implant, you want the implant to be really big to make it the most stable. Is that what you're saying?
Yeah, and I think in those high demand patients and even some of our lower demand patients that maybe have poorer bone quality, we want to select a larger implant because we're diffusing that load across more of that poorer bone rather than concentrating it in one small space.
And give us an idea of what a surgery would look like. Like, how long does it take? How long is the patient in the hospital? When do they start PT? When do they start exercising again, et cetera?
So usually if you're having an ALIF style procedure, you would meet your surgeon in clinic first preoperatively. He'll talk you through why he's selected an ALIF for you and sort of what you should expect for an ALIF. When I have those conversations with patients, I usually tell them, hey, next time I see you, I'm going to see you in the pre-op area. You're going to meet me and the anesthesiologist and the other folks from the OR. Usually you'll roll back to the OR awake. You'll go to sleep in the operating room, and that's where we position you for this ALIF procedure. You're sleeping for an ALIF much like you would sleep in bed at night. Your face is up, your nose is pointed at the ceiling, and your arms are kind of out to the sides. Everything's padded so that when you wake up, you'll be as comfortable as possible. But we're prepping your abdomen. This is a lot more like what you would think of for a general surgery type procedure. And oftentimes when we do ALIFs, we have a general surgeon or a vascular surgeon in the room with us for a lot of cases.
To do the approach, to get you to the
And
to
so,
the spine.
yeah, once we've prepped and draped the abdomen, usually we'll get access will be the next thing that we do. So we'll go down and we'll basically split the six-pack. You know, I can't see my six-pack anymore, but if you could imagine where it was,
it's in there
you would
somewhere.
see a split between the muscle pods. And we're going to split that rectus muscle and then get into the abdominal cavity. And then
So the approach is a muscle-sparing, minimal invasive approach too,
Correct.
through a small incision.
the great thing about the ALIF is you're not losing any functional muscle fibers. We're splitting mostly connective tissue to do this. We're keeping the innervation and the firing of the rectus to the right and to the left both intact, so that when we sew that connective tissue back together at the center of that six-pack, everything's still working the way it's supposed to, which is really an elegant way to get in and out.
That is a really good point. So one of the things about stability of the lumbar spine in terms of dynamic stability are the muscles that surround the spine. And the single most important muscle, and I'm biased because I did a lot of work on this, is the multifidus muscle, which is in the back. So if you can do the surgery all from the front without injuring the powerful stabilizing back muscles, it's a much less minimal invasive procedure. And functionally speaking, it's really rare that we get adjacent level problems after a standalone ALIF. Would that be fair to say?
100%. I think if you look through the literature, when you look at ways to fuse the spine, an ALIF is probably the way or the modality that we can fuse the spine with the lowest rate of adjacent segment degeneration. When we talk about adjacent segment degeneration, we're talking about this phenomenon where when we fuse patients, they put more force and more load into the next mobile segment above or below, and they can get premature breakdown of that level, which we hate seeing
Stiff
as surgeons.
segment increases the load at the level next to it,
Correct.
the fused segment.
And we used to always think that that was a foregone conclusion for our fusion patients, but when we really start looking at the data, there are definitely differences in how you choose to achieve your fusion and how that plays out for those adjacent segment rates. I think that has a lot to do with preserving the muscles like the multifidus, keeping from putting rods and screws in the back of the spine where we could irritate the small joints of the spine, and really trying to preserve as much of that posterior anatomy as we can.
Dr. Reddy, tell us a little bit more about what the surgery is like the steps and exactly what you put in and who's in the OR and how long the surgery takes, et cetera.
Sure. So for an ALIF procedure, after we get the approach done and we get access and we've gotten down to the front of the spine, one of the big things that we want to keep safe is two of the big blood vessels that run in the front of the spine. So a lot of times that's the primary focus of the approach, is get those blood vessels out of the way and get us safe, clean access to the front of the spine. Once we've gotten there.
And that's one of the reasons why you have a vascular surgeon or a
Correct.
general surgeon do the approach.
I do. I know surgeons who feel very comfortable doing the approaches on their own, and your surgeon may do his own approach. That has a lot to do with, where did you go to residency, where did you go to fellowship, and what you feel comfortable with. But I think whatever your surgeon feels comfortable with to get you a safe experience in the OR is something that you should expect, and we all do our best to keep our patients as safe as possible. So any of that is within the realm of normal possibilities for an ALIF. But I think once we get down there, the next steps are really where the spine surgeon, if you're using an approach surgeon, the spine surgeon and the approach surgeon almost switch places, and the spine surgeon takes over the dominant role of the case. And that's where we're going to go in and we're going to excise or remove any of the degenerative disc at this level. Most of the time we're doing ALIFs, the disc isn't in good shape and it's failed in some way. So we want to get all that soft, squishy disc material out of the disc space. And we'll remove that disc material, and we want to get back to a place where basically there's no disc material there. We've got clean, bony edges, and we can see all of our anatomy. If there's any disc herniation in the back or disc protrusion in the back or bone spur in the back, we've resected that and made more space for the nerves. And then we're going to start putting in an implant that is almost shaped like a little triangle. And the goal is really to wedge the spine open. The bottom two levels of the spine really should be the most curved levels of the spine. And when I say curved, I mean from a front to back perspective, not from a scoliosis perspective.
We call that lordosis.
Correct. We
That's
use
the
that
sway
term.
in your back.
Correct. And you should have a good amount of lordosis at L4 to S1. We lose some as we age, that's normal, but you really should have the most lordosis down at these levels. So we use these triangular-shaped, wedge-shaped implants, and we'll gently tap these in to try to reestablish that lordosis. And this will actually move the bones into the position that we want them in.
It jacks it up.
It does.
And there's even implants that expand as well
Correct.
once it's in place.
And the implants can be made of sometimes bone that's been harvested and milled and is clean and ready to be accepted by a new host. Sometimes they're made of a fancy type of plastic that we call PEEK, and that's a very biologically inert material that is easy to take pictures of after surgery and see whether the fusion's going well or not. And then certainly there's been a trend towards titanium-based implants that we know work very well and are very biocompatible. But any style of those, and there are some other materials as well, but we'll get that wedge in, and then a lot of times we'll fixate the wedge somehow. So some of the wedges have integrated fixation where there's small screws or blades going in to hold the bone. And then, sometimes it's, a true plate and screws that we'll put on from the front to hold everything together. And that's a very intrinsic patient-based decision based on bone quality and what our goals are of surgery again. And in rare cases, we actually have to pair the ALIF with a posterior-based surgery because there's some patients who are just so unstable that they need some rods and screws for that ultimate stability. I think we all as surgeons have patients that we don't feel comfortable thinking that ALIF is going to hold for the next 6 months, and we'll choose
because sometimes just putting in the implant from the front is not enough.
Sometimes it's just not enough
with
stability.
the screws in the back.
You have to imagine this implant's holding up half of a human being, right?
Yeah.
And so, for me, that
a good way to
implant's
look at
going
it.
to hold up a good, 100 pounds probably. And so, it's a lot to put on those small screws. And so if there are patients who have either disrupted anatomy in the back of the spine, previous surgery in the back of the spine, or simply we're just correcting a significant amount, those are typically patients where we're looking to fixate the back of the spine, or patients whose spine is inherently unstable. We're usually looking to add that stability. But then there are still options where we can place those rods and screws in the back of spine in a less invasive way or a minimally invasive way that still keeps that rate of adjacent segment degeneration low, still preserves that wonderful multifidus muscle in the back, but still achieves our goals, just helping patients get better faster. So post-operatively, when you come out of surgery, usually you'll land in the recovery room for a short period of time. We'll get your pain well controlled. We'll make sure that everything looks stable in terms of vital signs. We'll get you up to the floor if you're staying overnight. And that's usually where we want to start getting you up, right? Getting up can be up to the side of the bed. Getting up can be up in your room, strolling around a little bit, or maybe even going down the hallway. A lot of times, either the nurses or physical therapy will be walking with you to make sure that you're stable on your feet. We certainly will go slow with your diet after being in the abdominal cavity. We're really looking for you to give us an indication that you're ready to accept a normal diet. So that's things like robust, healthy bowel sounds, passing a little bit of gas or farting a little bit. For our patients, if they're burping a lot and they're not farting at all, we get a little nervous that when we feed them, they're going to start getting nauseous. But once we start seeing them, walk more, which usually helps with return of bowel function, then we start feeding them more aggressively. And our goal to get them out of the hospital is we want their pain well controlled. We want them safe to be up and around. We want their vital signs stable. And then if they feel like they can go home and manage this at home, they're much more comfortable at home than they are in a hospital setting. So usually 1 to 2 days in the hospital and we're able to get people home. I'd say for most of my patients, it's about 10 days to 2 weeks where they're a little more sore than they were before surgery. They're slower than they were. They're not going to win any races going up and down the stairs. That anterior incision is really the thing that limits them a little bit from a post-operative surgical incisional pain perspective.
How long do they have to take pain medicines for usually?
It's really variable. I think you can do the same surgery on 10 patients, and you have some people who do an ALIF and they take Tylenol post-operatively, and you have some patients who take something more. I would say on average, for about a week or so, our patients are on pain medication and then tapering off. But then, it depends on sort of how they do. But then I'd say somewhere at that 2-week mark, usually when I see patients back in the office, usually they're either off pain medication, maybe even driving themselves into their 2-week appointment and giving me a sense that maybe they're ready to get back to work in some capacity. And then maybe at that 6-week appointment, maybe getting back to a sort of more robust physical activity. And then by 3 months, usually no restrictions for them. So usually I make them wait about 3 months to like swing a golf driver or serve in tennis or do something that takes a lot of energy. But if you want to get back to, walking or cycling or something low impact for cardiovascular health, certainly very reasonable to do that between that 6 and 8 week time point.
Because of the bigger implants, is the recovery a little bit differently? Is the recovery different from the sense of how aggressive you can be postoperatively in ramping up somebody's activities?
I think so. I think it depends a lot on bone quality, and I think one of the things that predicts, post-operative speed of recovery is preoperative function. So for our patients who are in good shape, who have good nutrition, good core strength, and good activity level before surgery, we go pretty quick with them with an ALIF. In 2 to 3 weeks after surgery, we're really trying to mobilize them back to more physical activities. Certainly by 6 weeks, hoping to be able to get them into physical therapy if they need it or if they would benefit from it. And for most of my patients, between that 2 and 3 month mark, we're getting them back to golf or pickleball or tennis or some sort of high energy cardiovascular exercise. For office type work, we tell patients usually it's about 2 weeks at most that you'll be off work for an ALIF in our practice, but that can vary depending on patient specifics. And for manual labor type work, for my streets and sanitation workers and my folks who work for the city and have to do a lot of heavy duty labor, probably more planning like 6 weeks off and then getting them back maybe in a modified capacity. But certainly I'd say a good rule of thumb is at about 3 months out from a standalone ALIF, most patients should be back to their previous level of activity, back to doing the things that they love.
And every patient's different, but I've noticed that we're discovering early return to function and early mobilization is probably better than waiting too long, because all the timelines that I see seem to get shorter and shorter and shorter. And my patients that don't listen to anything I say and ramp up really quickly, during the first month, they torture me and their family more because of flare-ups. But at 3 and 6 months, they are a light year ahead of my nervous Nelly patients. So it's a bit of a balancing act, and every patient's different. But I'm impressed with how fast the recovery is for an ALIF, and it makes sense because it's a really big, stable implant. That's really helpful. For a patient that's listening, how would you summarize the key things that you want them to take away from this discussion?
So, your surgery itself should take about an hour to an hour and a half to complete. In most settings, you can do this either as an outpatient in an ideal patient who's healthy, hasn't had a lot of abdominal surgery before, has a lower BMI. Certainly, it's possible to do an ALIF as an outpatient. Some surgeons and practices will have regional variances that you'll stay overnight, or you may stay 1 to 2 days. Any of that is within the realm of normal possibilities. We also sometimes modify patients' diets for a short period of time after an ALIF, which is a little different than other spinal surgery. So there are times where we'll go a little slower with your diet after an ALIF, because we are in the abdominal cavity, we are moving around the colon a little bit and manipulating it, and sometimes patients are a little nauseous after surgery for a short period of time. So a lot of times people will be coming in after your ALIF and asking you if you passed gas or if you farted a little bit, and it feels a little silly or funny, but it's good information for the nurses to know. And I think once we see that return of bowel function coming back, we feel much more aggressive about getting patients, bowels moving, getting their regular diet back to them, and kind of letting them return back to their sort of normal activity levels.
Most excellent. Well, thank you very, very much.
No problem. Thanks, Joel. Thanks for including me.